Greeting online students. I'm going to be covering the basic concepts of critical care along with hemodynamic monitoring. Lots of fun stuff. At the end, I'll come back up on the screen and hopefully be able to show you a few of these things. But my best advice is to watch all those helpful websites that I posted. It will go over how to set up these hemodynamic monitoring systems, how to monitor them. Excellent information. Also, an excellent series on ventilation, mechanical ventilation, and how the ventilator works, the types, the modes, all of that. So I would suggest that you view everything. Also, at the bottom of your content module, there's a new section there about early alert systems and patients going bad and failure to rescue. Make sure you look at that as well. So look at all the content in the content module section. I know sometimes it's easy to feel that we do not cover our objectives. Why do they put those up there? They don't even cover them. They don't test over them. And we do. So I'm going to kind of prove that to you today because my test comes from everything that's on these objectives that's been posted and that I gave you before the break. You're supposed to read the PEDS book, page 631 through 633 and 690 through 694, not much in PEDS. MedSurg chapter 32 and then pages 770 through 771. So it's not a lot of reading. We're doing, as far as the content, if you're looking at, that's what we're covering. Roman numeral 1, which is about the physical environment, about pediatric considerations, about caring, stress management, teaching learning principles, critical thinking, and then I'm going to also be covering number 6, discussing geriatric considerations that could lead to increased admissions to the ICU. I've already covered in my other content that I went over, nursing management of patients experiencing acute cardiopulmonary disorders. And I'm going over red flags today. I've already been over ARDS and chest trauma and artificial ventilation. And then I will be covering hemodynamic monitoring with this one, and then meds commonly used. We'll be talking throughout about the importance of collaborative care, and that, the respiratory therapist is your best friend in the ICU unit. You should always be applying professional standards no matter what you're doing. So if you look at these objectives, I've covered all 6 objectives in this lecture content, and I've covered all the content areas, and that's what the test covers. So I know sometimes it gets frustrating. You think they didn't cover that, but we do cover it. All right, let's get started with some fun stuff, okay? I did post Tanners again in case you've forgotten, because I will have a question over Tanners and growth and development theories as usual. Pharmacology is always, so there will be pharmacology. All right, definition. Critical care nursing as a specialty deals with human responses to life-threatening problems. Life-threatening problems equals potential for death. It does require extra training to work back in the ICU unit. A lot of them become like ACLS certification has to be a must. Some become critical care nurse, get critical care nurse certifications. So it does require specialty. What about the physical environment? When you look at the physical environment, if you walk into most ICU units, they're set up relatively the same. A lot of open units with the nursing stations in the middle with many beds and curtains, bright lights. You will hear continuous telemetry monitoring, ventilators. You'll see lots of invasive lines, suctioning alarms, and visiting hours. And visiting hours have become much more lax than they used to be. Used to, in a 24-hour period, if you were visiting, you could only visit between such and such hours and such hours. Most of your ICU units now, you can visit around the clock with the exception of a few hours that they call quiet time. So the hours have become a lot more lenient, particularly when it comes to pediatric visitors. What about pediatric visitors in the ICU? Well, I have a wonderful handy-dandy article posted for you that covers that quite well, and you will need to read it because there will be a test question over it. Will be if you've read it, you should get it correctly. My best advice to you is to treat the patient, regardless of the condition, as if all their senses are intact. You want to assume they can smell, they can hear, they can see, and they can taste. They actually did a recent study, and they found that patients' memories was distorted when, of course, when they're in the ICU environment, and they find that distressing anyways. But after several months of being discharged, those memories and events slowly start coming back, and some of them are not very happy memories. They start remembering things that people said in the room. They become quite distraught over it. So you always want to be very careful. Unfortunately, I know of patients who went on the vent and came off and said, that they heard the nurses and some of the stuff they had said that was quite insulting. So you just don't want to do that. Do not ever, 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 ever be accused of doing that. If you're impatient when you're in there, the patient's going to pick up on that. They're already stressed anyways, particularly a patient who's got a ventilator and several other tubes. They're stressed as it is, especially if communication's an issue. And you're going to have to find out how that patient's wanting to communicate best. It may be with a communication board. It may be with pictures. It may be with writing out stuff. So you want to make sure it's already adding more stress to a stressful situation if you don't do that. So know where to find. Know where to find what? Know where to find intubation supplies, invasive monitoring supplies, the crash cart. Where's their medications located? Their oxygen. Is there ambu bags and they're in suctioning? Where do they keep their special trays, their Dopplers? What's their policies and procedures back there? Now, also, alarms. Alarms are set with certain parameters set. Silence does not equal ignore. So don't just keep going in there and silencing it because there's a reason it's going off. Always find the source or the reason that it's going off. So when you're on these units, the nurses will help orient you to find where these articles are. So what type of stressors could you think they're facing? Well, physiological and psychological. If you think about it, they could be in pain. More than likely, they're going to have fluid and electrolyte imbalances, infection, fever, appetite loss, bowel and urinary problems. Psychologically, their normal coping patterns are going to be altered. They may feel helplessness, hopelessness, loneliness. Changes in body image, fear of death, depression, and again, that big thing called communication issues. Your PEDS book talks about this a little bit, so be sure to read the PEDS section. It talks about the pain and the immobility, and this is on 631 through 633. That's in your assignment. Sleep deprivation, their inability to eat, their changes in bowel habits, unfamiliar surroundings. Just being in unfamiliar surroundings is frightful for both the child and the adult. The family's emotional needs are paramount when a child's in the ICU, so you're going to have to consider the family. They are having disruptions in their relationships. They're missing school, play, and play deprivation. So you want to be sure that you consider that if you've got a PEDS patient, they're going through some of the same types of stressors than an adult would. Environmentally, we've already talked about some of those, and again, those are the same for the PEDS and the adult. Psychoculturally, you need to consider again their age, the very young and the very old. The very old can even develop what's called ICU psychosis. And ICU psychosis is the experience of critical care that can elicit anxiety, fear, and stress. They undergo traumatic procedures. They may not be fully conscious, or they may be given drugs that have delirious side effects. So there's several reasons they may experience this ICU psychosis. So what can you do as a nurse to help with ICU psychosis? Patience and understanding. That's a big one. Patience. Number 2, identify and reorient someone who's confused or delirious, particularly throughout the day. Confused or delirious, reorientation. Encouraging a clear distinction between night and day. So have low-level lighting on during the night and bright lights during the day. So help ensure that clear distinction between night and day, because a lot of this ICU psychosis can be related to sundowning too. Ensure good communication. and minimize noise levels when possible. Boy, that's a big one. My dad was in the unit, and bless his heart, I remember we went visit him the next day, and his biggest complaint were the nurses outside talking all night long about what party they were going to attend or what they had done on the weekend and all this other stuff that he really did not care to hear about, as sick as he was. So just be careful, little mouth, what you say, because patients can hear that. Don't be screaming in ICU and yelling across the hall. These patients, again, any kind of stimulation to them can make the stressful situation even more stressful. You want to consider ethnicity, socioeconomic status, their religious beliefs, and incorporate those as much as you can. Don't always forget to assess their level of education prior to teaching. That's one of those teaching learning principles. And their occupation. For example, if they're a nurse, don't think they know everything just because they're a nurse. They don't know about. If they're an OB nurse, they're lost when they're an ICU patient. So you be sure to explain everything. If this isn't a child, you want to also make sure you're explaining things on their developmental level. So what's the methods to alleviate stress of cultural beliefs and values? Privacy, family interaction. Don't let them tire the patient, but they also need to be there to help the patient. Avoid sensory overload. Pictures from home are helpful. If it's a child, music, posters, favorite toys, blankets, iPods. Clocks and calendars for those who are disoriented to help reorient. You have judicious use of sedative medicine. Assess their understanding of information, and again, providing as much religious and spiritual values and belief system into their care as you can. So what about the staff in ICU? Is stress negative or positive, or can it be both? And it can be both, can it? You don't want it to get to the point that you're total burnout, negative, but having a little bit can also be a positive thing as well. So what are sources of stress to the ICU staff? The environment itself, just because of all the stuff that's going on and all the stimuli, the workload, even though it's based upon patient acuity and sometimes even one-on-one, sometimes that one-on-one can be a quite stressful situation. Interpersonal relationships that develop, and responsibility for decisions, big responsibility for decisions for ICU nurses. What's some strategies for managing that stress? Enhance your clinical knowledge and skills. Making sure you set priorities for the day. Make sure you have good communication skills. Evaluate your expectations of others and yourself. And most importantly, take care of yourself. Avoid the burnout. Pediatric considerations. Remember the 3 most common reactions that a ped has to hospitalization with separation anxiety, loss of control, and fear of bodily injury and pain. This is review. Separation anxiety, loss of control, and bodily injury or pain were the 3 most common reactions of all children. The emotional support to the family. We know stress is greater if it's an unexpected admission to ICU. Their most pressing need is for information. They're going to want to be kept up to date, just like anyone would. But a mother and dad who has a child that's in ICU, it's particularly important that you keep them up to date. Visitation should be liberal and flexible for these parents or significant others. And the most pressing need, again, is to be kept up to date. Their first visit, of course, as the nurse, you always want to accompany them back to there so you can give them support, so you can explain all what they're going to see before they go in so that they're not shocked. You want to make assignments and interventions that you can do to help when you're taking care of peds. Try to give that same primary nurse to that same ped as much as you can. And again, explaining things on appropriate age levels. As they are getting better and better, of course, start incorporating the use of play more and more. Some pediatric red flags that you would always want to look for in a ped to see if something's going wrong, or if you see anything you know something's going wrong, would be mottled skin, poor cap refill. Cap refill normal is less than 2 seconds, so anything greater than that is going to be abnormal. Cool extremities, that would be related to decreased perfusion. Decreased responsiveness. Anytime you have altered level of consciousness, that is a red flag for an adult or a ped, as well as decreased output. Bradycardia, restlessness, diaphoresis, tachypnea, nasal flaring, head bobbing, grunting, anorexia, retraction, stridor, and septic shock. Now, as you can see, these over here are your really bad red flags. You start seeing these and you really need to do something. If you see a ped that still has fever with a lot of these signs and symptoms and then starts getting a petechiae-like rash, always suspect septic shock. All right, so now what we're going to be talking about is hemodynamic monitoring. Okay. Invasive hemodynamic monitoring is used to provide information about a lot of things. You always want to get informed consent and be able to prepare a pressured monitoring system and set it up. Again, I have posted a YouTube video for you that will show you how to do this. If you come in and a patient has an invasive hemodynamic monitoring, these patients are usually serious ill patients that need more accurate measurements of their blood pressure, their heart function, and their volume status. So they're sicker. Take a drink. You will have what's called a transducer, and again, if you watch these YouTubes, you'll see what a transducer looks like. A catheter with an infusion system and a monitor. This is called the phlebistostatic axis here. And we'll talk about the phlebistostatic axis more later. And then you're going to need to know that you've got to have a flush system set up, a flush bag. So the catheter the catheter that's going to be in the arm is going to receive the pressure waves that's coming from the heart. And then this transducer right here, the transducer is going to convert that mechanical energy into electrical energy. And then that's going to be displayed as a waveform with numbers on a monitor. So the patency of that catheter has to be maintained with that flush system of normal saline in order to keep that line open so that you can monitor that waveform. Usually you're going to have 3 to 4 mils per hour of normal saline under pressure to prevent backup of blood and acute occlusion of the bag. All right, so let's first start out with the Swan-Ganz catheter. First thing they're going to have in place is what's called a cordis. And a cordis can either be in the jugular or subclavian, and it will be sutured. Then they will come in and they will take a pulmonary artery catheter and they will thread that into the correct port. The tip of that is fiber optic and heat sensitive, and it's going to pick up on readings. The balloon tip of the Swan-Ganz catheter can be inflated and deflated to get what's called a pulmonary arterial wedge pressure reading. So this sounds very complicated. All it is a catheter with a bunch of different colors that pick up a bunch of different pressures on a monitor. That's all it is, so do not get freaked out over this. Most of people who have Swan-Ganz catheters are people who are critically ill. Those who are very septic, those who've had a cabbage, etc. Okay. As far as a picture of it, here's a picture. You can see this one's going into the jugular. It's going to be here. You can see it's going through the superior vena cava, through the right atrium, the right ventricle, up into the pulmonary artery. And you can see that here it's wedged. This balloon can become wedged, and that's where you can pick up the pulmonary arterial wedge pressure reading. Okay. These different colors ports out here on here is going to measure different things. The proximal port will measure something. There's a thermostatic point. There's a port to the balloon, and then there's a distal port, and we'll talk about each one of those ports. So when we're talking about the ports, again, I said they're color-coded system. If you have the white one's usually the ones you hook your fluids up. And the one you hook your fluids up to is usually KVO. So you'll just hook it up to the KVO, whatever keep vein open status is at your hospital or protocol. The yellow port is the distal port. And the distal port measures pulmonary artery pressure, PAP. So this measures the pulmonary artery pressure, the yellow port does. This is inserted via fluoroscopy, the Swan-Ganz catheter, while monitoring waveform changes. The blue port is the proximal port, and it's your central venous pressure. It measures central venous pressure, okay? The balloon port, which sometimes is red, can measure pulmonary arterial wedge pressure, okay? The thermostatic connector is what, again, measures like cardiac output and temperature. And then you've got your oximetry connector that you can connect to get your SpO2, okay? Cardiac output, we know, is a reflection of venous oxygen saturations from your organs and your tissues. So that helps a lot to see how well someone is perfusing. So these are the ports. There are several ports. Remember in that picture I just showed you. These are the colors, and these are what it measures. So you will need to know that. So what does that mean, Miss Candler? Well, CVC, or central venous pressure, the norm for that is 2 to 6 millimeters of mercury. So you're going to have to know these norms. You're going to have to know these norms, okay? Now, when you see CVP, that is also stands for RAP. It's the same thing. Right arterial pressure, okay? Right atrial pressure means the same thing. So right atrial pressure, RAP, is the same thing as central venous pressure. And the norm for that is 2 to 6 millimeters. Cardiac index can be measured also when you have this intact. And cardiac index, the big thing you need to know about cardiac index, normal is about 2 to 5. Some books say 2 to 6. But the big thing you want to remember, if you get a reading below 2 on the cardiac index, they're in cardiogenic shock. A reading below 2, cardiogenic shock. So you can tell these are very sick people because you're trying to see how are they perfusing in the right atrium. What is their cardiac perfusion, their cardiac index? If they're not perfusion, it's below 2, they're at risk for cardiogenic shock. PAP, pulmonary artery pressure. Pulmonary artery pressure, you'll get a systolic and a dystolic reading. Should be 15 to 26 milligrams of mercury to over 5 to 15 milligrams of mercury. And there's a waveform in your book for you to look at, and that should be page 771. I apologize, I did not get that changed. On page 771. And it shows you the typical pulmonary artery pressure tracing, okay? And we'll go over that more in depth here in just a little bit. Then remember I showed you that picture, and I said it can wedge into the pulmonary artery. And if it does that, then you can get what's called a pulmonary arterial wedge pressure reading. And the normal for that is 4 to 12 millimeters of mercury. The SpO2 should be 60 to 80%. Cardiac output, 4 to 8 liters per minute. Okay. Now, these are the values I want you to know for test purposes. Always remember they're going to vary from facility to facility. So what do these pressures mean? Okay, let's go back up here and look at central venous pressure, okay, which was also called what? RAP, RAP, the right atrial pressure, same thing. If it is increased, let's say you go in and the reading's at 8, okay, and you're measuring pressure, then you've got increased pressure, right? So you've got increased right ventricular pressure. A lot of times that means an enlargement of the right ventricle, okay? Could mean hypervolemia, they're getting too much fluid, okay? And if you get a lower reading, lower than 2, then that usually indicates hypovolemia. So for most of these readings, if it's a high reading, then it's hypervolemia or hypertrophic. And if it's lower reading, it's hypovolemic. Okay. Again, cardiac index, we know if we get below 2, we're worried about cardiogenic shock. Over here with the pulmonary arterial wedge pressure, this is measuring left ventricular pressure. This is measuring the left ventricular pressure or failure. So if it's up, again, hypervolemia, you may have some mitral regurg going, some left ventricular failure enlargement. If it's lower than 4, then hypovolemia usually, hypovolemia. So you should be getting the ideal here that higher numbers are hypervolemia and lower numbers meaning hypovolemia. How do you get a pulmonary arterial wedge pressure reading? It's very tricky. It should be all of these readings, and it should be obtained from the critical care RN only. So the RN should be the one obtaining these readings, and always the RN should be the one getting the pulmonary arterial wedge pressure reading. Pressured readings, pressured measurements occur with the pulmonary arterial wedge pressure when you balloon it. And if you'll remember, I said the red port is used as the balloon port. If you watch that video, it will show you very easily how to do that, how they get this reading. But when measuring the pulmonary arterial wedge pressure, you will open the valve, you will inject air, 0.1 to 1 ml, and a lot of the syringes are actually predetermined and preset off so that you can't put any more of that in there, because the last thing you'd want to do is pop that balloon. That will close the valve. This injects air into the balloon after you close it. Then you'll watch the monitor for changes on the waveform, and you would expect to see a change when the pulmonary. When you see the monitor read the pulmonary arterial wedge pressure reading, you want to record the reading. Once you record the reading of the pulmonary arterial wedge pressure reading, you're going to see that, for example, if you look on page 771 in your book again, if you look on the left-hand side of the page, you will see the typical waveform that you'll always see. Then when you get the typical pulmonary arterial wedge pressure tracing, you can see that reading goes way down and almost flip-flops. That's when you know you've got the pulmonary arterial wedge pressure reading. You want to record that reading, then open the valve and withdraw the air and close it again. You never want to leave the air in the balloon. Then it will float back in place where it needs to. The waveform should return back to normal, and that's how you know that it went back to where it should be and the air is out. There are problems that can occur with any kind of pulmonary arterial catheter. If you don't get a waveform at all, you look up there and all of a sudden it's went blank, then you want to make sure you're checking all your connections, that a tube's not kinked, that the stopcock's not off, that you don't have some type of clot that's occluded. You can also have what's called over-dampening, where it gets real small, and that's usually because the catheter position may be kinked or clotted. Inability to wedge the catheter, the balloon could have ruptured. You want to make sure, if you suspect the balloon has ruptured, that you put them on their left side and that you get a chest x-ray. Care of the Swan-Ganz catheter, you're going to have to be flushing it every shift whenever they get up or change positions a lot. Depending upon the policy is how often you change the tubings. And discontinuing a Swan-Ganz, the first thing you want to do, of course, is pull out the pulmonary artery cath from the cordis. And always make sure that balloon is not inflated. So I always double check, get air, make sure I pull back to make sure there is no air in it. As you're pulling the pulmonary artery cath out, you want to pull it out very, very slowly, because you have to watch that monitor for dysrhythmias, especially PVCs. If this occurs, you want to stop pulling until the baseline rhythm returns. If that occurs, you want to stop pulling until the baseline rhythm occurs. Then you can DC the cordis after removing the sutures and hold pressure. Complications of Swan-Ganz can be pulmonary infarctions. You would deflate the balloon, reposition, cough, flush, and pull back the catheter and call the MD. Ventricular irritation occurs if it flows back into the ventricles and is sitting there beating on the ventricles. You can have a lot of PVCs and go into VTAC if you're not careful. If you start seeing waveform changes, call the MD. Air embolism, if it's a ruptured balloon, no resistance or waveform, again, you want to call the MD. Pulmonary artery rupture, if it's overinflated, you can actually rupture the pulmonary artery. That's why we use no more than 1.5 cc's of air, and usually 0.5 to 1 will get it. If you feel like you've overinflated it and they start throwing PVCs, of course, call the MD. All right, intra-arterial pressure monitoring, or ART lines. Indications that someone would need an ART line is hypo or hypertension. Frequent blood draws, someone's going to be getting like hourly ABGs. Certain vasoactive drugs, especially nipride. If they're on nipride, then you would want to have a pressure monitoring, and where you're monitoring that blood pressure very closely. This is also called an ART line or an A line. The ART line provides a way to constantly measure a patient's blood pressure, and it can be essential to stabilize a patient who is in ICU. ART lines can be inserted in the wrist, the radial artery, the brachial artery, the groin through the femoral artery, and also, if in extreme cases, the foot, if you had to. The same technique is used to insert a regular peripheral IV, except this one is sutured in place, and it's called an intra-arterial catheter. So it's a little bit longer and larger, but it is the same technique. Why would you want to use an arm board? Well, the arm board holds the wrist in gentle dorsal flexion position, so that's going to keep that catheter from kinking if the patient's bending their wrist a lot. Here you can see that they have set up their sterile field. The physician's at the bedside. You can see it looks typically like an IV cath, except it is longer, the intra-arterial catheter. The arm is restrained, you can see here, with the palm up on an arm board. And a number 20 IV cath is inserted until bright red blood is returned and you connect it to the tubing, and the first thing you're going to do is watch for a waveform. And this is what a typical arterial waveform would look like. If it's in the brachial or the femoral area, it may look a little bit different. This one is someone who has it in the radial. And we need to review the parts of this arterial waveform. So the first thing we have is we'll use this waveform here. As we're going from this point to this point is called the anacrotic limb. A-N-A-C-R-O-T-I-C, anacrotic limb. I've also posted this PowerPoint with my note pages that if you download, you will see my note pages at the foot of each of these PowerPoints. This represents this anacrotic limb here, from here to here, represents the rapid ejection of blood from the ventricle into the aortic valve. So going from the ventricle to the aortic valve, that rapid ejection. So from here, let me get my little marker to here. At the highest point up here, this is peak systolic pressure. So at your highest point is peak systolic pressure, and this is simply called the highest point. Then you have what's called the dicrotic limb. And the dicrotic limb is from your highest point to right here. This is the dicrotic limb. And the dicrotic limb from the highest point down to the little notch occurs as blood flows into the peripheral vessels and the arterial pressure begins to fall. So here blood is filling into the peripheral vessels and the arterial pressure is beginning to fall. Then you have what's called the dicrotic arch, and that's the spot that occurs in here. As you're going downward, you can see that little dip. That's a dicrotic arch. And that is that little notch, not arch, notch. That is the closure of the aortic valve in the onset of diastolic pressure. Then this last part, from the notch to the beginning of the next one, is known as the end diastolic component, the end diastolic component. Then you start all over again. You would start all over with the anacrotic limb, highest point, dicrotic limb, dicrotic notch, end diastolic component, start all over again. Now, you should check a manual pressure at least once a shift, and note that in your mind, that manual pressure that you get when you check it manually is going to be 10 to 15 milligrams of mercury lower than the reading that's on the ART line. So that's normal for it to be 10 to 15 milligrams lower on the systolic and diastolic than it is the reading on the actual ART line. Here's one of the overdamping wavelengths that you would see, waveform. Right now, again, this can be caused from different things. The trick that I want you to know, I just want you to learn the typical arterial waveform. If you ever get to where you are in this profession and you go into this specialty, you will learn more about it. But so for purposes right now, all you really need to know is there is over-dampened and under-dampened waveforms that can occur. But the big thing you want to remember is this is the typical waveform. The intra-arterial pressure reading monitor, parts of the ART line or the A line. You're going to have heparinized saline. You're going to have a soft tubing, a cap. You're going to have a transducer, stiff tubing from the transducer to the client, a pressure bag and dwelling catheter, priming of the tubing, and you want to watch for air bubbles. Pressure readings for the intra-arterial pressure monitoring, systolic blood pressure, should be between 90 and 140 milligrams of mercury. The diastolic blood pressure should be between 60 and 90 milligrams of mercury. The MAP, the mean arterial pressure, if you want to make sure someone's perfusing well, should be between 70 and 100. Between 70 and 100. Special considerations, you're going to be checking circulation. They're going to do what's called leveling and zeroing and flushing the bag. You always want to make sure when you put your bag on and you put the pressure bag on and you start blowing it up, that bag is pumped to 300 milligrams of mercury pressure. So you pump, 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 and eventually this thing will start dropping out at the bottom. And it'll eventually, when it gets to 300, you'll see a green line, and that means you're on the right spot, stop. So you would stop. And then if you start seeing like blood coming back in your tubing from your ART line, the first thing you'd always want to check is that pressure. Did it fall? Because sometimes that loses air. Did it go below that 300 millimeters of mercury and lose some air? If it did, then you just blow it back, pump it back up to 300. Some people now, best evidence-based practice says that plain saline can do just as well as heparinized saline. But if you do use heparin at your facility, it usually will come in a pre-mixed bag for you to use. The reason they're trying to get away from using heparin bags is because it's caused a lot of heparin-induced thrombocytopenia. So if you've got heparin and you're using it in your flush bag, you always want to check platelet counts. This does require informed consent. Remember the Allen test. You'd always want to do that prior to putting anything into the radial artery. Alrighty. The MAP, the mean arterial pressure, you want to know how to figure that. And again, this is the average pressure within an artery over a complete cycle of one heartbeat. So it tells how well that you're perfusing the coronary arteries. So in order to fuse the brain, the kidneys, and the coronary arteries, it has to be at least 70. Okay? 70 to 100, 70 to 110, you'll see different readings. But if you're doing 70 to 100, you're perfusing okay. So how do you get this? It says it's 2 times the systolic plus the diastolic divided by 3. The diastolic counts twice as much as systolic because 2/3 of your cardiac cycle is spent in diastole. So if you had a reading of 140 over 180, what would your MAP be? So it's 2 times the diastolic, so in this case 80. So 80 times 2 would be 160. And you would take 160 plus your systolic pressure of 140. That would be 300. And once you get your 300, you would divide it by 3, as in your thing, and that means that would come up with a MAP of 100. So if you come up with a MAP of 100, you would know that that patient is perfusing fine. Intra-arterial pressure monitoring can have complications. You can see there is a long list of them, from hematomas to infections to occlusions to hemorrhages to air emboli to dampening. You always want to do circulation checks. Check the pulse, check the cap refill, check the warmth of the arm. They will set the alarms about 20 above and below the patient's baseline. And you want to make sure that you're setting those so that you catch someone before they get too ill. Site care and tubing changes are very important, and you'll do those per policy. Flushing the bag is real fun, and we'll show you how to do that. Leveling and zeroing. Zero sounds like it's something very hard, but it's really just kind of calibrating You just simply turn the capstock up to the transducer. The numbers will go to 0. You push 0 on the 0 button on the monitor. That zeroes it out, so a flat line comes up 0 after 0. When that occurs, you've zeroed out the machine or calibrated it. Turn the stopcock back on the transducer, and the waveform should reappear. And you always have to make sure when you're doing this, you're doing it the phlebostatic axis, though. Okay. And I showed you a picture of where the phlebostatic axis was earlier. Your setup will look like this. You'll have your arc line, your pressure bag. Let me go back here a little bit. So the phlebostatic axis, you will go down from the nipple line all the way down, and then from the armpit down to the lower rib, and about halfway in there, that is your phlebostatic axis, where that picture is that I showed you. That's where you will line up your transducer when you zero it out. So this transducer over here would be, transducer here would be lined up with the phlebostatic axis. Okay, so you'll have a pressure bag. You'll pump this pressure bag up right here up to 300. A little thing will drop down here that shows 300 millimeters of mercury pressure. The pressure bag will go through the transducer. The transducer, then you'll have your machine coming back through. Going to the arc line. The arc line will go through the transducer. We will come through here and do an electrical activity and put a typical waveform on the monitor. Here you know all of these, the anacrotic arch, the highest peak, the diacrotic limb, the diastolic notch, and then the end diastolic. Then you've got your saline-filled non-compressible tubing as well. And this is what a typical arc line would look like. Never ever inject anything into an arterial cannula or an arc line. Concentrations of drugs into tissues can result in cell death and can result in something similar to this. So you would never ever want to be responsible for this. It can result in necrosis, gangrene, limb ischemia, loss, amputation, permanent disabilities. All right, ABCs, no D's or F's accepted on this exam. Do well.